Hi, everyone, and welcome to today's Webinar Wednesday, which is Misinformation and Disinformation as Critical Threats to Public Health, Best Practices in Identifying, Responding, and Building Resilience. Our presenter today is Dr. Anthony Dissen. So just a couple housekeeping notes as we get started. If you want, I have opened the chat. Please put where you're from in there. And if you have any questions for our presenter, please put those in the Q&A and Dr. Dissen will answer those at the end of the presentation. So a little bit about our presenter today. Dr. Anthony Dissen is a tenured assistant professor of health science in the School of Health Sciences at Stockton University. As a public health and population health educator and researcher, his scholarly work focuses on the intersections between queer and gender non-binary communities and the health care system, particularly in areas of cultural competence, body liberation, and nutrition considerations of queer people. In addition, Dr. Dissen's work explores how nutrition and health information is shared, understood, and utilized by consumers of health information, particularly through online and social media channels. So with that, I'm going to turn it over to Dr. Dissen.
Wonderful. Thank you. Thank you, everybody, for being here. This is a topic that is near and dear to my heart, and I'm sure it is near and dear to your minds and thoughts as well, as this is one of the key topics of the day, is it not, of misinformation and disinformation, particularly as it comes to health and public health. I mean, we could probably speak for the next 7 hours about this and not run out of things to discuss. And so, for our short time today, thank you so much for giving a little bit of a intro about me. This way, this has already been covered. There's just a few things that I want to talk about and share today and have some discussion about with you all. So, first and foremost, what is the difference between misinformation and disinformation? While they are, of course, quite related, they do relate to not only different impacts on the health of the public, but they also refer to different intentions and different motivations behind the sharing of some of this information. What are some of the factors in the literature that's trying to be looked at to see what can explain which people, which communities may be more susceptible to misinformation and disinformation tactics that exist? What drives belief persistence? And this is a really important topic for anything, of course, related to health, but especially when we're trying to combat incorrect information that people might be susceptible to. How do we understand what drives that persistence? Why are some people just hell bent on not changing their opinions on vaccinations or this or that? What is it that seems to drive some of these behaviors? And then how can we build resilience? And how can we strengthen literacy through activities like pre-bunking and what sometimes referred to as misinformation inoculation? How can we almost treat this like a vaccination to build resistance within people so that when they come across misinformation, they have perhaps some of those antibodies, if you will, ready to question, at least with some critical mind, the information they're coming across. So, shortly, misinformation is any kind of information that is shared that is false or misleading, but is not motivated with the intent to deceive. And this is really a key distinction then from disinformation, where there is the deliberate sharing of misleading, of incorrect, of false information with the more specific goal to manipulate, to cloud the mind, if you will. And then of course we could have malinformation, which is using true information out of context specifically to cause harm. And this distinction, if not, honestly, if almost nothing else comes out of our time together today, I believe these three areas of distinction are key. And the reason why I think we as public health professionals really need to be thoughtful about this is if we treat all incorrect, let's say, information the same, it can actually derail our abilities to educate people, and it can derail our abilities to build health literacy and to do some of that pre-bunking and inoculation within people, because sometimes information is shared without the desire to cause harm to health. It's just out of context, or it's wrong, or it's incomplete. And that does not need to be treated in such a way where the person sharing the information is being treated like a public health enemy. And we can see this sometimes where we can sort of tear down certain belief systems, if you will, or certain approaches where there's really not malicious intent behind it. So our approach shouldn't be to call out this person, this group, this organization, this platform as harmful, because this can then lead into them that belief persistence of people saying, no, this is correct. And it almost becomes more of a defensive act versus how can we help you correct some of the gaps or some of the misinformation that we're seeing here versus people that are actually going through disinformation or malinformation intentions where their goal is to cause harm, to manipulate, to mislead. And that needs to be treated differently, where it's not about necessarily trying to disprove the information. It's more about showing the true intent, the true desire for harm behind the platform. Now, of course, I feel like this isn't going to be news to most of the people here, but just as a quick refresher, if you will, a reminder, why does this matter? So we might think, well, there's wrong information, there's misleading information. All we need to do is share the correct information, and everything will be fine. Well, we know, of course, that this is not true. That no matter how much correction, no matter how much correct information we try to put out, misinformation, disinformation persist. And one of the reasons for this is that we see in the literature misinformation spreads fast. False news, incorrect news, incomplete news, misleading news spreads much faster. Truth, when things are spread through, again, things like media channels, social media, etc., typically diffuses to about 1,000 people, whereas misinformation can spread upwards of tens to 100,000 people. And the reason for this is that misinformation and malinformation and disinformation tends to be sensational. It tends to be associated with emotions like fear, surprise, disgust, anger. Truth tends to be more focused in the emotions of trust and joy and security. And it's an unfortunate truth that these other types of emotions, like outrage, they fire people up more. If somebody spread something on social media, for example, that said lots of fruits and vegetables are good for you, that's not going to get shared 100,000 times on social media because most people will think I already know that. And most people will say, okay, it's not exactly going to fire people up. But if information is shared saying, did you know oatmeal is killing you in the morning? People will share it. Half of the people might share it because they think it's true. Other people might share it because they think it's false and they're angry about that false statement that's being made, but nonetheless, that emotion of anger, of outrage, of shock drives the spreading of this information more. And so when we think about the ways in which people are engaging with information, especially in an increasingly digital age, we have to recognize that misinformation taps into emotional parts of the populace that allow these messages to spread much more quickly than when we are trying to spread truthful information. Another, of course, serious consequence of the proliferation of misinformation and disinformation in our world is that it erodes trust in not just one area of public health, but across multiple dimensions of public health. So, this was a study that was just recently published looking at the last few years about different trusted institutions in the United States: fire departments, libraries, hospitals, pharmacies, public health departments, schools, police departments, universities, and social services agencies. And what we can see is that there has been an ongoing gradual decline in trust of 8 of the 9 sectors. The only area that seems to be weathering the storm a little bit more as fire departments, interestingly enough. And what is particularly important and what we need to be paying attention to is that Gen Z, those individuals born between about the late 1990s and about 2012, consistently report lower levels of trust in institutions across the board. So, especially as we are thinking about our outreach and our efforts to combat misinformation, generationally, we see the Gen Zs who are now, based on the age range they're in, are entering into their high school years, into college years, if you will. In general, consistently do not trust institutions, schools, public safety, and public health. There's also, of course, very strong impacts on the behaviors and behavioral choices of people. We use the internet We use social media. People use internet and web-based sources of information first, especially when they are seeking out health information. And we as public health professionals need to understand that people are not going to stop using not just websites, but social media, Facebook and X and TikTok and YouTube and all of these different platforms. This is where people are going for misinformation, for information, excuse me. And very often, public health professionals are absent from these platforms. A recent evaluation of different popular social media posts found that about a third of posts that were identified as being sources of misinformation were associated with the potential changes in behavior associated with harm. And so, for example, engaging in toxic, expensive, or dangerous therapies. There's been a lot of research about explosions in people checking into emergency rooms and emergency departments for severe liver damage caused by natural products and supplements and things like that that they've seen online. This can also lead to emotional damage. People don't trust. People feel feared. They don't know who to trust. They may feel like there's no hope. Well, this website says this and this website says this. There's no hope of knowing whether this is good for me or bad for me. This is true. I mean, this is very real and and when we look to see, we don't often see a lot of public health professionals and health professionals creating platforms, creating accounts on these websites to share not just accurate information, but emotionally connective information that would get people to, whether we like it or not, to click, to share, to like it, to post it and repost it. These are the realities of how information is being spread in our world and in our culture right now. And we have to be part of it in order to not only combat this misinformation, but to give people hopefully a safe and trustworthy place to go to. This in particular starts to pull into susceptibility because we know that misinformation and disinformation campaigns disproportionately affect populations who are already what we might think of as vulnerable. Subject knowledge, information literacy, numerical literacy, analytical thinking, trust in science, all of these things correlate strongly to resistance to health information. On the contrary, or on the flip side of that, conspiracy thinking, conservative ideology, conservative party identification has consistently been shown to lead to greater susceptibility to health misinformation. Understanding these demographics and understanding who is and is less vulnerable is important because if I am going to share information that assumes people know different levels of risk, that assumes people know how to understand numerical information, that assumes people understand even what science is. Well, these are people who are probably already equipped with the skills to have a bit more critical thinking, to allow them to think thoughtfully before they accept or reject health information claims that they are seeing, especially online. But older adults who may not have grown up with that level of digital savvy, people who are in more impoverished areas, people who are part of different racial statuses or sexual minorities that might be more susceptible to misinformation because of bias, because of discrimination, because of minority stress, tend to be more susceptible to misinformation campaigns that come out. When we think about this as a health professional, as a behavioral health scientist, as a public health professional, social media use in general is associated with susceptibility. So, social media remains a strange creature to work with because, in some ways, those who use the most social media are more susceptible sometimes to health misinformation claims because they are exposed to them more. But at the same time, these are the very environments we need to find ourselves in to combat and to provide trustworthy, understandable information that is also culturally competent to the vulnerable populations that might be bombarded with these misinformation claims more. So it is an imperfect situation that we find ourselves in. But nonetheless, we know that if these are the places people are going, they are the places we need to be. And this requires active engagement and not passive correction. And I think we as a field continue to fall behind in this area, that approach to misinformation tends to be correction. Somebody puts a statement out there that XYZ behavior, I don't know, circumcision, vaccines, etc., Tylenol use is associated with these outcomes. Instead of being actively engaged in putting statements out before these statements are even made or before they get shared by major media channels, we tend to say, well, no, that's not true. But that again leads to people feeling a sense of hopelessness. Well, this group said it is true, and now you're saying it's not true. Who do I believe? In a recent study, they found that the most common reaction to misinformation by healthcare professionals and by people engaged in this world is typically to just ignore it. Don't listen to them. Don't pay attention to it. That kind of passive approach just doesn't work. Individuals who engage with misinformation tend to have some similar traits. They tend to have lower education levels and they are predominantly male. So we need to be targeting ahead of time men, particularly men with lower education levels, again, people who might be part of certain vulnerable groups, etc., to say, you may hear certain statements come out. Here's why we want to give you the tools for you to know whether or not they are correct or not. So, how do we educate a potentially lower educated population about health literacy, about numerical literacy, about putting these things in perspective? This is active engagement. This is getting out there before the next shocking claim is made and before the next vitriolic claim is made to say, you're going to keep seeing things, they're going to seem strange or they're going to be confusing. Here's how to work with them. And we'll talk more about that in just a little bit. And again, we can't downplay the role of negative emotion. Negative emotions play a very strong role in how people engage with misinformation. When people feel outraged, when they feel angry, and especially when they feel that they are being judged or laughed at for listening to some of what we might call conspiracy theories, that tends to lead people to drive down into that belief persistence more and to stick with saying, no, I am right and you are wrong, if for no other reason than to just not feel a fool. Interestingly, in this study that I've listed here, individuals who agree most commonly with misinformation psychologically have also been shown to have certain traits associated with what is sometimes called that kind of narcissistic or Machiavellian personality. Again, showing that there are very strong emotional and psychological factors at play. And some of these may go beyond our particular scope of practice, but this is why we as public health professionals need to be bringing in and collaborating with mental health professionals and other people, education, especially for younger people, educational professionals, to see how do we better screen for people who might be a bit more susceptible, to these kinds of claims, and how can we help to support them, to educate them, to give them the tools they need, to have some protection before they fall into that level of susceptibility. So, what else can lead to susceptibility? It's not just lower levels of education and it's not just anger. There's some other key factors that can lead to this as well. What is interesting is that prior knowledge does not necessarily always protect people from misinformation. So it can't just be sharing facts and figures. It can't just be giving a class or a lecture like this even on a particular topic. We need to think about the actual skills and particularly the cognitive skills that are important when it comes to piecing apart health claims. And that's what can make our work so difficult is that it isn't just any information, it's health information, and health information can be complicated. So first and foremost, people with lower levels of analytical thinking and numerical thinking tend to have higher levels of vulnerability to misinformation. So again, as we collaborate ideally with school systems in particular, both K-12, higher ed, community ed, and other areas, how do we create a population and help to support and educate a population that can better understand numbers, that can better engage in analytical thinking and critical thinking? It doesn't just have to be solely tailored to claims around health misinformation. It's anything, because we know these are the tactics that is often used, not only by misinformation, but malinformation and disinformation campaigns. manipulation of numbers, making things sound much more complicated than they seem, confusing correlation and causation. We can't just look at the community. And this is one of the things, if nothing else, that is a big pet peeve of mine is when anybody in healthcare talks to a patient or a community member or a group of people and says, well, do your research. People don't know how to do research. Healthcare professionals don't know how to do research, right? Research is a skill that takes time and education to build. So when we kind of, again, passively just say to people and say, well, do your research, that's an impossible ask if we're not providing people the skills needed to understand research information and research data. So it doesn't mean that we have to train everybody to be epidemiologists, but we do need to seriously be putting our efforts out there to educate people on some basic critical thinking and numerical thinking skills. Unfortunately, it continues to be shown in the data that political ideology and identity shapes what people accept to be truth. Part of this can be because of what is called inattention account. People want accuracy, but people are stressed, they are busy, they are cognitively overloaded, they are rushed. So if my identity group, that could be my political party affiliation, that could be my religious affiliation, or anything like that, says this is the truth, I may be more likely to just accept that because I am exhausted or I have 100 other things I'm trying to pay attention to. And then we also have what is called motivated reasoning account, which is people tend to accept misinformation if everybody else who's part of their social, political, etc. identity group also accept and support it. So, this is where we need to make sure that people who are part of different religious or faith based organizations, where people who are also affiliated with different political groups and ideologies, but who are also themselves champions of truth, that want to know the truth, that want to support public health, are being supported, are being lifted up into levels of leadership that they can say to people who are also part of the same political ideological group or same in the same social group, religious or faith-based group, no, it is important. No, vaccines are safe. No, it is important to do these different things. We need people who are part of the other, if you will, the group that we sometimes feel is maybe not always in support of public health. How can we help create support systems for the voices who are part of those very same communities that others can turn to and say, well, I trust you. I mean, this is a basic part of public health practice in general. You have community members who are trained to be educators. In my area of work in nutrition and dietetics, if we're going to do nutrition education in communities, especially let's say near where I live in Camden, New Jersey, they don't want somebody that does not look like them, sound like them, understand the reality of their life going in and talking about healthy eating habits. It's just going to come off as disconnected. But if members of the very community itself can be trained, can be educated, can be given the tools for support, that can go out and be educators, there is already that higher level of trust. So that same kind of approach, that same kind of model can be adopted here so that people who are part of the community, who are part of the identity group, whatever it is it might be, can be given facts, if you will, can be given the correct information and to go out and try to be ambassadors for that truth within their organization. Interestingly, in research done especially by Van Der, we have all of these different ways of actually using epidemiological frameworks to track how misinformation spreads and to model it in this way, just like we would track the spreading and modeling the spread of a virus. So false information again spreads fast and farther than truth. But if we look at it almost from a pathological perspective, we can see who are the super spreaders? Who are those people that are generating the most misinformation? How do echo chambers amplify misinformation and prevent correction? Exposure does not equal belief. Just because somebody clicks on something or listens to a podcast or sees a video doesn't necessarily mean, of course, that they're automatically going to accept that viewpoint. People often share misinformation again because it's emotionally engaging or interesting or provocative, not necessarily because they immediately believe it. And again, this is just something we have to take into great account and to start to pay more attention to of How do we then share information that touches people's emotions in a way that gets them to share it, to spread it, to say, isn't this interesting? I hadn't thought about it this way before. What do you think? So we can get our own inoculation going, so we can get our own spread of information going. So, what drives persistence in belief? Again, political. And that's why, of course, which I don't think I'm sharing any information here that's too groundbreaking, but it just as a reiteration, politics and politicians in particular play a very powerful role in the spread of both correct and misinformation. And part of this is because a lot of people who go into politics aren't always coming from a science background, right? They may have studied law, they may have studied political science, they may have studied criminal justice, if they've studied anything at all. But we don't often see a lot of people go into either local, state, or national levels of political leadership that have backgrounds in science, that have backgrounds in public and population health, that have backgrounds in healthcare. So we have people entering into positions of great power, influence, and authority that themselves may not have the numerical thinking skills and the critical thinking skills and the basic knowledge skills in healthcare. So, what are we doing to get public health trained people, scientifically trained people, into local, state, and national levels of political leadership? And it doesn't have to be of any particular political party. It doesn't, I mean, if anything, it should be of every political party. We need people that understand numerical information, that understand science, that understand basic statistics to be in these roles so that they themselves can be more informed when they're voting on bills, that they themselves can be more informed when they're holding town halls, that they themselves can share on their own social media platforms information, both either in support of or against the latest claim that's been made. But we must be part of the political landscape. It can't just be even in an advisory role, as important, of course, as that is and needs to continue. But how are we, especially with up and coming generations of public health professionals, are we encouraging them to take on these levels of political leadership? And are we doing what we can do to reach out to our local, state, and national political leaders and offer education, offer uh, information, offer thought points, offer guidance? We know, again, in research, health professionals can sometimes be some of the least politically engaged. We have some of the worst voting records in terms of actually showing up to vote. And we often don't call our representatives often because there can be this thought that, well, that's the tumultuous world of politics. I'm in my area of practice over here. We can't afford to stay out of the discussion. In a large scale analysis of about 400,000 tweets over the course of a year in the early 2020, 2021, right, of course, at the time of the COVID-19 pandemic, what we saw was that misinformation dynamics were shaped by the national media system and political polarization. Far right conservative parties accounted for most of the misinformation across countries. This was specifically the United States, the United Kingdom, Germany, and Italy. So again, we will be in our next pandemic. We will be in our next major public health crisis soon, right? Whether that's in 5 minutes or in 5 years. What are we doing now? And this leads us a little bit to what we'll be talking about next of inoculation and sort of pre-bunking. What are we doing now to ensure that we again have political leaders and systems that are more publicly thoughtful when it comes to health information? Some of the psychological drivers. So again, cognitive factors, people that rely on intuitive thinking versus analytical reasoning are more likely to believe false information that just feels correct or that just doesn't feel correct, right? That people who fall in that more personal sense of intuition. And of course, people who have repeated exposure to information, especially if it is perceived to be accurate, will tend to lead to a sense of belief, even if people know better. Even if they really deep down know that this probably isn't true, more exposure to something, especially if it's presented in a level that appears to be accurate, they may start to believe it themselves. People are more likely to accept misinformation that, again, aligns with their identity. So, what does it mean to be a member of a particular state, a citizen of a state? What does it mean to be a member of a particular profession, of a particular, again, religious or political background? How are we working with sociologists? How are we working with educators and psychologists? This is that kind of interprofessional engagement we really need to talk to people, talk to faith leaders, to talk to local, again, leaders to say, what is it to be somebody from New Jersey? What is the identity of that? And how is that shaping people's belief? And it might seem kind of like a strange thought, but it is. People will do something just because they're from Philadelphia, and that's what people in Philadelphia do. All right, so how do we create an identity of Philadelphia that is associated with good, strong public health values? Many people value accuracy, but again, are exhausted. So this goes back to that idea of that inattention account. So people are just exhausted and tired and distracted. So it's not that people don't care about the truth. It's not that people don't care about health. It's just hard to put one more thing on their plate. So fact checking, debunking can help reduce belief. And that's typically what we see as a public health response is just, hey, check your facts, check your sources. If you come across information, here's better information. It's short-lived. It doesn't reach a lot of people. It doesn't help the way that we would like it to. So better ways that we can respond to misinformation is what is called pre-bunking and psychological inoculation. So inoculation, just like that we would inoculate against a foreign body like as a microbe. How do we inoculate people against the next wave of misinformation, disinformation, or malinformation they may come across? First and foremost is forewarning. We let people know that, hey, there's going to be attempts to persuade you. And this is a really key word here, to persuade you. People don't want to be tricked. People don't want to be manipulated. People don't want to be bamboozled and made a fool of. So, is that again an emotion that we can utilize to our benefit to say there are forces, there are groups, there are attempts to trick you? And I want you to be aware of that so that we can move into step two, which is preemptive refutation, which is how can we provide an effective rebuttal immediately to provide people, the viewer, if it's a video, the attendee, if it's a class, with the tools needed to counter misleading information they may see in the future. The idea here is not so much to say I can prognostify what the next crazy statement is going to be. Instead, here are some things you can look at, signs, some red flags, if you will, that lets you know, ooh, this might be somebody who's trying to trick me. This might be somebody who's trying to persuade me. So we're letting people know and start to notice and pay attention to the signs of misleading, especially that purposeful misleading like disinformation and malinformation. We're giving people little inoculations, little microdoses, if you will, little dead viruses, killed virus vaccine of weakened examples of misinformation so that we're not trying to get them to believe in the misinformation, but we can show sort of old, maybe obviously silly, but still important examples of misinformation from the past. So they start to build that awareness and a little bit more of a keen eye for what they may see in the future. So there's a really fantastic resource, this pre-bunking resource. I'm going to put a link to this in the chat when I'm done with my talk in just a little bit so that if you would like to download this PDF and have this as a resource for yourself, you have it available. I'm just going to share a couple key findings, if you will, from this resource on how we teach people, how we inoculate people before they're exposed to misinformation so that they have that resistance, they have those antibodies, if you will. And this is what is called pre-bunking. So first and foremost, we want to let people know what are those techniques, what are the signs that they are trying to manipulate you. First and foremost, impersonation, making it seem that a more credible organization or person is sharing information. NASA admitted that the climate change occurs because of the Earth's orbit around the sun, right? It gives it an aura of authority. NASA, this is what they should know, right? Whether this is true, whether this is manipulated, whether it's an outright lie, we let people see examples of how people will take groups, organizations that are so large it can be hard to pinpoint down whether it's true or not, to give the idea that a more credible source is sharing something that is false. Emotional manipulation. Again, sharing examples of, what this integrative health practitioner did was so heartwarming and empowering. Doesn't mean they're wrong. It doesn't mean that there's anything wrong with integrative health practices, especially if they're evidence-based. But we can let people know in this example, did they really actually show evidence of what this person did, or are they just tugging at my heartstrings? Polarization, showing exaggerated differences between groups. If someone's saying, don't believe this group because they're liars who are only motivated by profit and money, big pharma, big this, big that, it's not that I have to prove to somebody big pharma doesn't or doesn't exist. It's not even about disproving the truth that unfortunately, yes, there are financial and profit-based motivations in healthcare, but it's showing more that if someone's trying to make it seem that an entire group is bad, is evil, is wrong, that's an example of manipulation. Conspiratorial ideation, something that really can't be proven or disproven, but again, it's scary. Vaccines are just a way for billionaires to make us sick with mercury. Just these kinds of claims that are just inflammatory, but it can get somebody who may not know differently or may not have the tools to know differently can feel worried. Ad hominem attack to the person, targeting the person, the speaker, the individual to move away from the argument. Don't trust that Anthony Dissen. He's a known liar. We can't trust him to give a quality webinar, right? It's not about the content. It's not about the information. It's not about the data. It's about the person. So when people derive to this person is bad, that can be a sign again of potential manipulation. A false dichotomy. You either believe in science or you don't. That is the kind of claim sometimes we make in healthcare, right? Either you believe in the science or you don't. Well, that's there's not just two sides to this. That completely ignores the gray. So we need to make sure we ourselves are not falling victim to making some manipulative kinds of statements. That just because somebody has a concern about whether they should get the HPV vaccine for their child doesn't mean they're a science hater. It means they have concerns. Maybe they've come across some of these examples that have led them to feel fear. So before I say, well, you either trust your pediatrician or you don't, you either trust the science or you don't, we need to give some spaciousness to have a larger conversation. False balance, presenting a debate as if both sides of the debate are equally balanced. Some believe that the earth is round, but people like Anthony Dissen out there believe the earth is flat. Well, just because somebody says that doesn't make it true. So we want to make sure that we're educating people that sometimes there are not always two balanced sides to the same story. And this goes back just very briefly to why we need to be involved in political leadership, but also educating our politicians. Because in political science, what are a lot of people taught? There's two sides to every point, there's two sides to every debate. So that kind of training can fall into when people are looking at science or health-based arguments where sometimes there aren't two equally balanced sides. There is a side that has a decades of data to support it and another side that has someone's blog to support it. Those two things are not equal. But if I am not trained in scientific process, scientific thinking, I may be susceptible to the idea that no, these two things are equal. Few other quick things that, again, just for ourselves and as well as that what we can do for our community members. We have different levels of research, and we can see this sometimes used in not so much always in the most malicious attempt, but sometimes in that just pure misinformation, just incomplete data or data that's not always representative in a particular area. So, at the lowest level of evidence, which might still be good quality science or research, is just foundational evidence. Animal based research, speculation, in vitro research, or even a little bit above that, case reports and case studies, expert opinion, observations. These are not going to be at that same level of research as a prospective comparative study, of a randomized controlled trial, of a meta analysis. So, we need to make sure also as people are sharing science, are sharing data, even from good quality studies, that we're putting them in their proper place. I think a good example of this often is what we see very popular right now with claims being made about longevity, whether it's about a diet, intermittent fasting, only eating 750 calories a day, or a supplement, or this. People will say, well, this supplement will make you live longer because this supplement was shown in a medical study to cause people to live longer. Well, when you look at it, no, it helped yeast cells in a petri dish somewhere live a bit longer. That doesn't necessarily translate to human studies. Media may not know this. Other people with platforms may not know this. So, what can we do? Short of enrolling people in an introduction to research methods class, what can we do to again educate the public of animal-based research, cell-based research, lab research isn't always the same thing as what we would see in outcomes in humans. It's not me telling people they're wrong. It's not me telling people they're a liar. It's giving people something to think about. If it was done in mice, it's interesting, it's provocative. A mouse isn't necessarily a human. If it was seen in a human, but it was a case study or a case series, interesting. But I don't want to know what just happened in 10 people. I want to know what happens in 150,000 people. And so we can help people be guided through this process a bit more before they cling to ideas. So we need messages that are clear, that are empathy centered, and that are appropriately repeated. So there was a recent commentary that just came out in JAMA about how people misinterpret medical numbers because they frame an emotional response around them. So, for example, if a treatment expectation, it could show completely numerically identical information, telling people 3% versus 3 out of 100, telling people 90% recovery rate versus 1 out of 10 didn't recover. These all might be factually true, but each of these has a different emotional and psychological response in somebody. We need to be thoughtful around language like rare or unlikely, because this can amplify anxiety in people when there's not proper context. Telling people 1% harm versus 1 in 100 is very different. And we need to be very thoughtful about this because sometimes we can be a bit matter of fact about the way we share information. Again, thinking, well, this is the data and I'm just going to share it. Numerical literacy is low. So we need to find ways to acknowledge people's concerns, to build trust and openness, to allow people to share their uncertainty and their fear, and to validate that uncertainty and fear, and then provide messaging that is empathy centered, still numerically accurate, but is more empathy centered versus more blunt. Again, a resource, I share this with my own students and I share this with colleagues as well. I won't belabor this too much. I'll just point out a couple key things that I'd like to look at here. How we can spot some bad science and how we can help our community members and the people we serve spot bad science. And one of the easiest things to do is just to make sure that we're helping people understand the difference between correlation and causation. And I know that might sound like an overused, come on, we've heard this 100 times, but it still holds true. A lot of things we come across, if it's correlational research, we need to let people know how to understand that just because two things are happening at the same time does not mean that they are related to each other. And again, just giving people simple examples helps people, again, get that little bit of inoculation, that little bit of knowledge right ahead of time before they immediately cling to this belief. Another way that we can help people understand information is to avoid sensationalized headlines, or at least to be wary of them. Right? Science is, admittedly, a long, slow, tedious field. And that's a good thing because we don't want to build guidelines and policy and recommendations on the flash in the pan finding. We want the preponderance of data. We want decades of data. We want the latest study and the next study and the next study that shows this seems to be the direction to go in of this elusive thing we call the truth. So if we can work with people to say if something comes out that sounds sensational, headlines about how everything we knew about heart disease was wrong, everything they've been telling you about vaccines is wrong, everything we knew about drug resistance bacteria is wrong. It can just let people know, oh, that might be a sign that this may not be true. It might be oversimplified. It might be misinterpreted in some way because science is not sensational. We only know things are groundbreaking in retrospect. That, oh my goodness, the work done by this organization 15 years ago really did lead us in some pretty incredible directions, but we don't know that at the time. So just helping to guide people through some current examples or past examples of sensationalized headlines, sensationalized topics and headers on social media posts can help the person look at that and say, ooh, that looks like that example they showed me. Maybe this isn't immediately true. And then lastly, which again, these are all very important, but things we can try to do for the community is non-peer reviewed material. And this is just, again, something we can let people know that anybody, for better or worse, has access to platforms now. I mean, that is one of the biggest things that changed with social media in particular. And even with website designers like Squarespace and GoDaddy and others, is it used to be you needed to know how to code to put information online. And that was time consuming, it was tedious, you had to be really skilled, it was expensive. Now, for free, I can in 3 minutes create a YouTube site, create a TikTok site, create a Snapchat, create a this, create a that, host my own domain on Squarespace. I can do WordPress, and people can just start to share information. And we need to let people know that just because something is online doesn't necessarily mean it's quality information. That there are things we want to look for. That there's little signs of, did people cite a study? Is this just someone's opinion? Maybe their opinion is informed, maybe it isn't. But we need to let people know that true information needs to be critiqued and critiqued by peers. And when it's just somebody sharing their opinion, their personal experience, it doesn't make it wrong, but it doesn't make it true either. Lastly, this is a wonderful resource developed by Michael Caulfield on competent fact checking, excuse me, for web-based information. This was originally designed for fact checking political statements and political messages that we find online, but we can do the exact same thing for health-based information too. And it's simple. It doesn't require people to have access to a medical library or to a university library to do these things. So, what we can ask people to do and educate people to do is that when they come across a claim, we can check for previous work. All right, so Google, go on websites and just start to explore what are other people saying about this? Has anybody fact checked this yet? Most people are finding information that is not original, meaning somebody else is talking about a study or a finding or this or that. So, did they tell you where the information came from? And again, I'm not expecting people to know how to access PubMed, but if I'm seeing information published on a website or a video on somebody's social media site that has no reference, that's a sign that, well, then where do I know where this person got this from? We can read laterally. What's the reputation of the author, the group, the organization, or this claim being made? What's being discussed about it? And after that, we can circle back with this information we've obtained and evaluate. It is not perfect, but it gets people to think. It gets people to build those analytical skills, those critical thinking skills. It gets people to be curious. And as far as a public health approach to this, of course, we as public health professionals can go far many levels above this to actually analyze data, et cetera. But what does that do for the person in the community that can't do that, that doesn't have the skills or the access to resource? I can put them in a position to say, well, let me show you how you can try to fact check any information you find online a bit more thoroughly. It helps a lot because it helps people, again, not feel foolish. It helps people to not feel like they are being seen as dumb by their healthcare professionals or the people they're looking out for. And it allows them to remain curious and come back and say, well, based on the checking that I did, here's my thought. And it allows there to be dialogue and it allows there to be discussion. That is what we as public health professionals can do to build resilience and to, again, pre-bunk and to inoculate against misinformation. It's helping people tap into what they believe, why they think they believe it, and what the emotional response is, and using that to our advantage. It's not to say that we don't give out factual information, that is still important, but it can't just be sharing bland data. It can't just be sharing emotionless data that does not seem to lead to long-term changes in behavior or long-term changes in trust. So what I would like to do now is take some time. I'm going to again put that link in the chat that I was talking about. But I want to take some time if anybody has thoughts, questions, anything they would like to share about what's been explored today so far, while we have some time to do so.
Yeah, great. Thank you so much. And thank you for sharing that link. I believe the last question there was just about that link.
Yes,
So,
absolutely. So that if anyone
um,
that's not working for anybody, let me know.
yeah. So just as a reminder, if you have any questions, please put it in the Q&A section, and I will ask those to Anthony right now. So our first question is, what what are the most immediate threats to public health that are rooted in misinformation in the United States right now?
So, of course, as we know, one of the more immediate ones is vaccines. And vaccines are interesting because they are almost a victim of their own effectiveness. Because in a relatively short period of time, there are so many illnesses that have become sort of a thing of the past because they have worked so effectively. And because of that, there can be this false idea, I think, in a lot of the population of, well, it's done. We did it. Polio's gone and measles is gone. Or even if it came back, it wasn't that big of a deal because I don't see examples of children who have become blind from measles or who have lost their fertility due to measles or somebody becoming paralyzed because of polio. So I believe this is one of the more important issues that's threatening us right now is the the belief that we are beyond illnesses that can be caused by pathogenic organisms, or that even if we get them, it's not a big deal. This was many years ago, but I remember there was a person who was talking about why we don't need to be vaccinating our children, and he said something to the effect of, uh, it's not a big deal. If you get measles, you just stay home. You're sick and you'll be fine. And that's what happened when I was a kid. And everybody, it's just again, it's that false narrative that you can't prove, you can't disprove, but it touches people's emotions in this way. So this continues to be one of the things we as public health professionals need to do, is to let people know why these things still matter. Why does a flu shot matter? I don't know anybody that dies of the flu. Well, that's because people get flu shots. But I mean, as many people here probably know, this has been a horrendous flu season, and there has been an explosion of complications, deaths, and hospitalizations because of flu. Finding ways that we can share this information with people that's not from a shaming perspective, but these are why these things still matter perspective is one of the most important things we have to keep putting out there into the public.
Yeah, I definitely agree. That is definitely true. All right, I have another question. We have somebody who's a current dietetics student, and they just have a question about what drove you into academia education. They're interested in becoming an RD, but this field sounds super interesting as well.
That's wonderful. First of all, I'm very happy to hear that. And we need more dietitians that are involved in research and public health in this way. So, what drove me and perhaps other people here too, in different fields as well, is I started my career in outpatient care. So, I was working with people in outpatient settings, and I really thought that was it. That I was going to spend my whole career in that area. But what I found very early was that people were profoundly confused. And this is really what spurred my interest in misinformation, was because people would say, well, I heard I shouldn't eat this, or I heard I shouldn't eat that, or that all disease is caused by processed bread. And I spent so much of my time in these sessions trying to do education that then I then started the hospitals I worked for to do community health and to do community health lectures where I could talk to dozens of people at once versus just one person at a time because people have questions. And then that just continued to move more in the direction of academia and research of wanting to be part of the efforts to better educate future professionals and of course members of the community as well. So for me, it was really seeing firsthand the lack of knowledge. I don't mean that to sound like an insult, but the real lack of knowledge people had about different areas related to health and their real genuine confusion about what health looked like. And so that's what really kind of moved me in that particular area.
Yeah, that's great. We've worked together for so long and I didn't know that. So
Oh,
that's
yes.
great. All right. Our next question is, what are some ways governmental public health agencies address misinformation when trust in the CDC is at an all-time low and agencies depend on this institution?
What a fantastic question, and it's an important one because we are in precarious times. And for the first time with the MPH students that I work with, I have had for the first time ever had to say, please don't cite the CDC in your work because it has become less reliable as being unbiased, and especially if nothing else, having up-to-date information. And that's a terrible statement to make. And so, what I have been trying to do with both my students, but also, again, members of the community, or what public health agencies can do, et cetera, is to work at the local level. Because I think that is where people's interests are typically going to be more focused, but it also tends to be less caught up in the mire of federal policy and federal statements and guidelines. Is, what can local public health agencies do in their immediate environment? What are the questions people are asking in their communities, and um, how can they be addressed? How can we go out into schools, or how can we do community health fairs, or be in the places where people are, and have it be more almost conversational, have it be more dialogue based. I think that can help because there's 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 not too much we can do to address the distrust that exists at the more national and federal level right now. Just as, of course, people are very confused about some of these statements that are being made. But what can I do here in my county? At least can feel a little more tangible, can feel like something I can get my hands around, and to do topics such as this. So, for example, it's not necessarily saying I'm going to do a lecture about how policies that are being made at the federal level are wrong or anything like that. It could just be, here's how to identify good quality information, or here's signs of truth versus signs of misinformation, that can be more neutral, if you will, that can be more general, and especially using examples from the past as opposed to maybe always using some of the more immediate examples, can help spare us some scrutiny that we're going against current guidelines. It could be more based on, well, in the 90s or even the early aughts, these were statements that were being made. How can we use the skills we've talked about to piece them apart? It can feel, again, more educational and historical, because I see some of the comments here, there's just words people can't use, or there's things people are afraid to talk about. Using the reality of the situation and the times we find ourselves in, how can we still share generally helpful guidelines of spotting misinformation, that anybody of any, again, background, any affiliation, any ideology could learn from, and use in some level of critical thinking from there, if that makes any sense.
Yeah, for sure.
And I agree with what Erica is sharing here. Again, yeah, using things like WHO, NHS, some organizations that have information that's less politically influenced, can be helpful as well.
Yeah, great, great suggestions.
Yes.
All right, one last question. And this one is about social media. So,
Mm.
how can we use social media to help address public health misinformation?
I think by whether that's you as an individual, or whether you create a social media for your organization, whatever it is the realities might be, I, getting in the fray of it. I mean, I think social media can be a tool. I don't know if this came across anybody's platforms in the early days of, again, especially not just the COVID-19 pandemic, but especially as the mRNA vaccine became available. There was one young man, I can't remember his name, but he created these like videos on TikTok where he would hold forks in his hands, and that was to show the little prongs on the outside of the virus, and how RNA would look at that. Like, they were very silly, but that spread very far and fast because, again, it was emotional. It connected to humor, it connected to sort of entertainment. But it was in a 30-second video. He explained to people how an mRNA vaccine works. No, it doesn't stay in your system forever. Here's how it degrades. Here's how it helps protect you from this virus. We can create, especially, this is where, if we are partnering with universities or schools, younger people who might be really media savvy and really content savvy that know how to make entertaining, high quality videos. I couldn't in 100 years do that. But to make the kinds of things that are shareable, that are easily distributed, and that would get people to, again, to click, to like, to say, I just saw the funniest video, but it also informed me about I don't need to be afraid to give my child the HPV vaccine. So being part of that, it doesn't always have to be, again, an anger of I'm going to disprove all the misinformation in the world. It could just be people have questions about this. I made a video about it. People have questions about this. I made a little cartoon about it. And getting that out there into the social media sphere where people can post it on their Instagram stories and people can share it and reshare it and make sure that we're getting our information to spread a little more powerfully than it is in the past.
Yeah. Well, great. Thank you so much for all those questions, everyone. I hope that this is a very informative session for you all. Special thank you to you, Anthony, for being here today. It was a great topic and very relevant. So, as I
Always a
mentioned
joy.
before, we had a lot of interest in it. So, thank you so much for being here.
Thank you. Thank you, everybody, for being here, and thank you for the opportunity to share.
Yeah. Everyone have a great day.
Be well.